Started on part 2 of chapter 11, Airway Management, for the EMT lecture series. So we'll just dive right in. So we talked on the previous slides in the previous video about factors that affect ventilation, right? And so now we kind of shift gears, and of course these are not entirely dichotomous, but examiners and academia tries to split them a little bit. But now we're talking about oxygenation and respiration, right? Remember, ventilation is the mechanical process of moving air in and out of the lungs, right? So things like a neural injury, like a nerve or a brain or spinal cord or a nerve injury, trauma, different types of like mechanical obstructions, right, can cause ventilatory issues for us. But now we're more so talking, well, like when we get down to the alveoli and there's this whole hemoglobin oxygen thing, what happens, what affects this? What are the factors that can affect this? And the reason that this becomes talked about is because something that's interesting about medicine is upon every part of normal physiology, there is pathology, right? So at every level of our cellular respiration, there could be pathology. And so that's where, as medical professionals, we intervene with pathology and we fix it. So let's talk about that. So an external factor that can affect oxygenation and respiration is this stuff called carbon monoxide. We've talked about this quite a bit. Remember that CO, carbon monoxide, because it can bind to hemoglobin and cause a false pulse oximetry reading. You might be saying, like, if you're either going to be thinking, wow, I've heard this 10 times, I got it. And if you're not, let me explain this one more time. This is very important. This is heavily tested. We've talked about this a lot. We're going to talk about it even more because it's very important to know and understand why this happens. So we're going to draw our little hemoglobin here, right? A single hemoglobin molecule. They look like little donuts, okay? Biconcave disc. So what happens is normally we want oxygen to bind. And in fact, normally you can bind 4 oxygen to 1 hemoglobin molecule, okay? And so that's what normally happens. Well, what happens is when something burns, it could be a log, or it could be a house, or it could be exhaust fumes from a car. The byproduct of combustion, one of those is carbon monoxide, CO. Do not confuse this with carbon dioxide. That is the byproduct of cellular respirations. Remember when cells and electron transport chain does their work, it produces CO2. This is different. This is carbon monoxide. Students get this confused and it drives me nuts. Carbon monoxide is the byproduct of combustion, aka when stuff burns, it produces CO, a poisonous, clear, odorless gas that you cannot smell or taste, okay? And so what happens is the CO in the air will come around and it'll try to bind to hemoglobin. Well, the problem with this scenario is carbon monoxide and hemoglobin, really good friends, okay? They're about 240 times greater friends than hemoglobin and oxygen. What does that mean? When you have just straight up CO floating in the blood, it will bind to that same hemoglobin molecule 240 times stronger than oxygen, okay? So we know that hemoglobin really likes to find CO and pick it up and hold on to it. It has what's called a very high affinity to it. So they bind really tightly. And so when we talk about what is pulse oximetry is just measuring the saturation of hemoglobin. It doesn't, and remember, this is like the little thing you put on your finger at the doctor's office and it shoots out a percentage and your pulse rate, right? And so what it's measuring is, oh, wow, the hemoglobin is bound at 99%. Well, that's really useful in most cases, right? 99.9% of the time, that's really helpful. But it's the first of winter. You're called. The whole family's complaining of dizziness and nausea and vomiting and lightheadedness and altered mental status and hypoxia. Leave out hypoxia. You wouldn't know that immediately. And so and you might be wondering, like, oh, what is this scenario? Well, it's the heater was turned on. It's leaking carbon monoxide into the house. All of them have now reached toxic levels over the night, and they all have CO poisoning. So what happens is when you put your pulse oximetry on this house and these patients, it's going to read 100%. Why is it going to read 100%? Because they don't have a lot of oxygen bound to their hemoglobin. In fact, they're going to have very little. Right? But what it is going to be bound to is carbon monoxide, okay? So all the pulse oximetry is measuring is how saturated is the hemoglobin. It doesn't know if it's bound to carbon monoxide or if it's bound to oxygen. It can't tell the difference. The only way you can tell that difference is through a blood gas, through a blood test, which is not done in the pre-hospital environment. So what happens is you have to assume any time that someone has been exposed to carbon monoxide, a heater, a car, a furnace, a boiler, a grill, a fire, a campfire, a stove, an oven, whatever, you have to assume that if you're thinking, oh, this could be a carbon monoxide poisoning, that just because it reads 100%, they are in fact hypoxic. They are in fact have very little oxygen in their blood because all their little hemoglobin molecules are sucked up by carbon monoxide. And so when it reads 100% in carbon monoxide poisoning, it's falsely elevated, okay? The hemoglobin is 100% saturated, but it is not truly 100% saturated with oxygen. And so what's the treatment for this? Well, I'm glad you asked. It's high flow oxygen through a non-rebreather. Okay, so we're going to talk about what this is and how it works, but this will provide around 90% oxygen through this mask. And the idea is to saturate the blood with oxygen, and hopefully whatever hemoglobin is left can bind on to that oxygen. The long-term treatment for this, it's interesting. It's actually, well, this doesn't happen as much as you think, and the books will say, but the long-term treatment is hyperbaric therapy. So it's where you go into this chamber, and it's truly like 100% oxygen in this chamber. It's like a pressure vessel. Almost looks like a big propane tank, right? So you put people in that, and they stay in there for a while, almost like a submarine-looking thing. And it'll stay at 100% oxygen for a while, and hopefully and it's also under pressure, right? So it's 100% oxygen under pressure, and so it'll hopefully force oxygen into the hemoglobin. This gets really complicated because a red blood cell's life is around 4 months. So really, if someone were to ask, well, how long does it take to completely get rid of the carbon monoxide? It's about 3 to 4 months. It takes a long time for this to completely go away and resolve. Now, the acute setting, you can fix this in a couple hours, but just some interesting stuff about this. So just be on the lookout on your exams. If they tell you, guy fell asleep in his car with the engine running, it was a very cold winter night and they started the first campfire, they heated the furnace for the first time, or patient was removed from a burning house, or whatever, okay? Carbon monoxide. You need to be thinking carbon monoxide. Now, I will jump off a little bit and say, okay, so this is an interesting thing, and it doesn't have anything to do with Airway, but okay, let's say someone's in a house fire, okay? Big old house fire, and they die. What do you think was most likely to kill them? Was it the heat? Okay, one. Was it carbon monoxide or was it cyanide? It's not the heat. It's carbon monoxide and cyanide first. Usually carbon monoxide will kill them first. What's cyanide? Cyanide is one of the byproducts of combustion of inorganic materials like carpet, sofas, upholstery, cushions, clothes, stuff like that. It produces a gas called cyanide, which shuts off, actually it's interesting, shuts off the electron transport chain. So just a kind of fun little factoid for you. People typically don't die from burns and house fires first, right? They die from like hypoxia from carbon monoxide typically. Now, all right, moving forward, that's enough on that. Please be aware of that. Watch for that on exams. What are some internal factors that can influence oxygenation and respiration? These are the conditions, as I'll just read this to you, conditions that reduce the surface area for gas exchange. So think about this. If we have these little grape-like structure boys down here, and you have something that's obstructing these, right? Mucus, inflammation, chronic inflammation, scarring, like fibrosis, that happens in COPD, sarcoidosis, pulmonary dysplasia, stuff like that, pulmonary edema. So if these guys are sitting under friggin' water, how much gas exchange is going to take place here? Not a lot, okay? So these are all medical conditions that we're going to talk about throughout this series that we need to be aware that can affect, respirations respiration, oxygenation, gas exchange, okay? So these are all, again, I'm going to kind of give you some examples on these because these are really important to know. So there are non-functional alveoli. So this could be for a lot of reasons. This could be from past damage. It could be from an obstruction like a mucus plug, or it could be clamped down from like a asthma attack or something like that. Asthma does tend to be systemic, as in it tends to affect both lobes equally, but the more distal ones could end up being shut off first. And then this is a very interesting concept. that students get lost on, but it's super interesting. Okay, this thing called intrapulmonary shunting. What is this? So let me just draw this out for you. Okay, so we have two lungs. Okay, and so this is the patient's right, and this is the patient's left. Okay, so within the lung sits the heart. This is not drawn to scale, but the heart sits here. Okay, and so what happens is, let's just say that you have a big O green pneumonia down here in your right lower lobe. Okay, well, what will happen is your body will be like, there's like a lot of pus and snot and shit down here. So let's go ahead and just shut off this part of the lung for blood flow. And so what it decides to do is like, you could send some blood down here, but you're really not going to pick up a lot of oxygen. You're probably just going to pick up a bunch of bacteria and mucus and pus. So we'll just shut it off. Okay? And so what happens is it shunts, as in it moves blood from like the whole part of the right lung being perfused. It'll just shut off this part of the lung and say, don't waste your blood down here because you're not going to get anything out of this area, or you're not going to get enough. So what happens is it'll just perfuse these two areas of the lungs. That's intrapulmonary shunting. And so how this happens is through pulmonary vasoconstriction. And so that's one example of pneumonia, but this could also happen with a pleural effusion or pulmonary edema or a peanut stuck right here and blocking off the entire right lung, right? It'd be like, whoa, there's not a lot of oxygen over here. Just shunt it. Send all the blood to the left lung. That's an extreme case, but send all the blood to the left lung because we know the left lung's working, okay? And so this process is called, it's slang for shunting, but it's called intrapulmonary shunting, okay? Obviously, respirations, pain, and strong emotion. So if someone's in pain, do you think they breathe tachypnic or bradypnic, right? It's tachypnea, right? They're breathing very fast. And you've experienced this. If you're in pain, you're not breathing slow, right? You're breathing fast. Hypoxia, remember that's low oxygen. What's low oxygen in the blood? Hypoxemia, right? Very closely related, pretty much the same thing for our intents and purposes. And of course, other conditions that affect the cell can affect this. But, shunt's good stuff. That's important to know that when people are shunting, it's shutting down a portion of the lung that's not functioning properly, and it'll shunt it to a portion that's working better. That's how I'd recapitulate that in one sentence. Now, circulatory compromise can obviously affect oxygenation and respiration, right? So, if the heart's not working, obviously that'll affect how much blood's getting to the lungs. So this could be a cause of cardiogenic shock. So if someone's heart's beating 30 times a minute, right, not a lot of blood is getting delivered to the lungs. So that's going to affect oxygenation and respiration. Sure. But it could also be obstruction of blood flow. So if someone has like a hemothorax or a pneumothorax, we've talked about what a pneumothorax is. Remember, that's when your lung collapses and it starts pushing up against the heart. So this could be from like a gunshot wound, or, we talked about what's called a spontaneous pneumothorax, when someone like coughs really hard and they blow a lung, typically tall, skinny men, or those with emphysema, asthma. So what happens is you can eventually start pushing onto the heart, and especially the great vessels like the inferior vena cava. And so that can cause something called obstructive shock. We'll talk about that more in chest trauma. So other conditions you can talk that we could encounter that would affect oxygenation respiration: pulmonary embolism. Remember that one? Remember, that's like the flight attendant or someone who just had surgery who has the red swollen leg below their knee, the clot, which is a clot in the deep vein thrombosis. So then it busts loose and travels up to the right side of the heart into the pulmonary artery. And so then you block off a portion of the deoxygenated blood so it doesn't make it to the lungs. And what type of mismatch does that create? A VQ mismatch. So that is like a pulmonary embolism. Who gets those? People that are stagnant and or those that smoke on birth control are two things to watch out for. And we just talked about a pneumothorax, hemothorax, open pneumothorax. The problem with pneumothorax is what I described, right? When it becomes a tension pneumothorax and it starts pushing onto the great vessels. The inferior vena cava is pretty large, but it's pretty soft. So it's not like an actual garden hose. I would say the aorta is more like a garden hose out in your garden. The inferior vena cava, it's more of like a bendy straw. It's very easy to squeeze on it and collapse it. So that's something to be aware of. And that's a general concept, right? Arteries are rigid, veins are not. And that's due to capacitance. So heart failure. certainly will affect this. What's the lung sound we hear in heart failure typically? Didn't hear anyone answer that. I'm just kidding. So the sound we hear in heart failure is crackles, right? So it's going to sound like they're breathing underwater a little bit because blood will start backing up into or not blood, but fluid will end up backing up into the lungs. Okay, so crackles or rails, cardiac tamponade. I'll draw this for you really quick. It's kind of complicated. Again, we'll talk about this in trauma. So if this is the heart, there's a little sac that goes around the heart, and normally there's fluid in here. Well, what happens if someone gets a steering wheel to the chest, and let's just say you break a piece of the heart right here, and it starts bleeding into this confined cavity. The pericardial sac's very thick. It's almost like a thin leather, so it doesn't have any elasticity, or doesn't have much elasticity. So this can end up filling with fluid and pushing on the heart. Excuse me, and that'll cause obstructive shock. It's another form of obstructive shock. Hemorrhagic shock, right? So remember, hemorrhagic shock is a subtype of hypovolemic shock. So hypovolemia means not enough volume, low volume. But hemorrhagic shock is someone's hemorrhaging, right? Maybe they got shot in the face, or maybe not the face, the arm, and they hit the brachial artery or something like that. So yeah, hemorrhagic shock. You can also have hemorrhagic shock from poop and blood, vomiting blood, like esophageal varices, okay? Very important to realize that hemorrhagic shock is not just a trauma condition. It is, in fact, I wouldn't say that, but it's very commonly a medical condition that we encounter, right? People vomiting or pooping blood. Vasodilatory shock, what type of shock is that? Is it distributive shock, right? So this is when the vessels vasodilate, and so they increase, or they become leaky, and then you end up with a decreased preload, and you end up with fluid leaking into the third space. So yeah, that would be vasodilatory. So what causes vasodilatory shock? Anaphylaxis, neurogenic shock, sepsis, right? Those are all forms of vasodilatory shock. Acid-base balance, I feel like we talked about this a lot, so I'm not going to dive into this very deep, but I'll give you the high yield ones for each of these and what they are, okay? Respiratory acidosis. Who gets this? This is someone who's not, I'm not going to type, I will actually, fine. Not breathing enough. So let's just say they're breathing, I don't know, 5 times a minute. So they're going to build up CO2, which is acidic, and it's going to make the blood acidic. That's called respiratory acidosis. Respiratory alkalosis. This is someone who is breathing too fast. Who gets this? Someone who is anxious. Okay. Metabolic acidosis. Who gets this? DKA, sepsis. Interestingly, an aspirin overdose, especially in the later stages of it, right? So those are good examples. Metabolic alkalosis, astronomically, well, I wouldn't say it's very rare, but this would be like overdose on like bicarbonate. So like someone who overdoses on like GERD meds, so like acid reflux meds, like Tums and stuff, bicarbonate, you can end up with metabolic alkalosis. It's very rare for that to happen. So those are some good examples. Excuse my terrible handwriting, but you get the picture. All right, so the thing is that we need to be able to quickly recognize, does the patient have an airway or not? Good thing is, generally, if someone's talking to you or if they're crying, they have an airway generally. So I tell students all the time, right? Like a crying baby is a beautiful sound because that means that they have an airway, okay? Someone who's yelling or something or talking to you, they generally will have an airway, so that's good, okay? So we walk in the room and we should immediately be looking, are they breathing, right? Do they look dead? And, they make eye contact and, hi, my name's Hunter, I'm a paramedic with PCHDMS. Oh, hey, okay, good. They have an airway. It's great, okay? And so we need to see don't use words, this drives me nuts. Don't use words like they're breathing good. They're breathing good. What is that? What does that mean, right? So the answer would be like, patient appears to not be in stress, they have non-labored breathing. So the words like non-labored, not in distress, better than good, don't use the word good. It's just not medical and it's not academic, and it's actually, I think I saw someone got crucified for saying a 12-year-old is breathing good the other day to a physician. The physician lost it, rightfully so, right there on the student. And so the normal respirations are 12 to 20, okay? Now, could someone sleeping be breathing 10 times a minute? Sure. If I were to go walk to the mailbox and back, could I be breathing at 24 times a minute? Sure. So as a general range, it's 12 to 20. I will say the National Registry and your exams will typically honor that code. Okay? Exams typically honor the code of 12 to 24 adults as the respiration rate. How do we count respirations, right? We don't tell the patient that we're counting their respirations because that can create a bias. And so what you do is you just look at their chest, look for chest rise and fall. If you need to, you can put with permission, put a hand on them, right? And just count, right? Count quietly. So you can count for 30 seconds and multiply it times 2. You can count for the whole minute. Do you. But just be aware, you should count respirations. You're not that good to walk in the room and be like, they're breathing 16 times a minute, right? You're not that good. Okay, if you actually count them, you're going to see that you're wrong. So don't do that, especially in EMT, at least in school, don't do that. Really shouldn't do that in practice either. Okay, now someone could be breathing 12 times a minute, but they're breathing very shallow. And that's something we need to observe and report and make an opinion on, okay? Or they could be in that, and we're talking about their adequate depth and tidal volume. Or someone could be breathing 12 times a minute and they're breathing really deep, just right, really deep, and that means something, right? So you have to be aware of what we call tidal volume. Remember, tidal volume is the amount of air that you typically breathe in and out. And how much do we normally breathe? It's about half this bottle. This is a liter, right? You typically breathe around 500 milliliters of air with each breath in and out. Okay, and then moving forward, for an adult, we're talking about adults right now, by the way. Regular pattern of inhalation and exhalation, right? So we're going to talk about Cheyne-Stokes and Biot's and Kussmaul respirations, right? So we got to make sure that they're breathing rhythmically, and that they're not holding their breath or gasping or having periods of apnea, which means that apnea, of course, means not breathing or without breathing, and that they have clear and equal bilateral breath sounds. So remember, we take our handy dandy. When there's controversy, they call these like doctor stethoscope or something like that. You take your handy dandy stethoscope and you listen to all lobes of the lungs. Okay, we're going to go over this very heavily in class with how to do this properly. It's easy if you do it properly, but I see this messed up a lot, which is okay. We're here to learn. Okay, and by the way, guys, I'm not like bitching at y'all. I want us to be the best EMTs and paramedics possible. So that's why I'm like trying to point out where I've seen people go wrong, so we can make those mistakes in the class and become better. So that's why I'm pointing these out, okay? I'm not hating on students or being hypercritical. I'm just allow us to learn from past people's mistakes. So you want to listen to breath sounds, and you also have to make sure that there's bilateral chest rise and fall. So if it's a 2-year-old child and you notice that only the left side of the chest is moving and the right side of the chest is not moving at all and has absent lung sounds, you might think, oh wow, they've choked on something like a peanut or a battery or a coin. So these are all things that we look for, and over time, this becomes very natural and fluid. But it's not going to start off this way, and that's okay. So that's why we're talking about it. Okay. Now, of course, respiratory distress can be a cause of a lot of things: upper or lower airway obstruction. Okay, inadequate ventilation. Okay, so we're going to have inadequate breathing effort, impairment of the respiratory muscles. This could be for a lot of reasons. We've talked about why. Impairment of the nervous system. A lot of reasons. We've talked about why. And dyspnea. Remember, dyspnea means the medical word for shortness of breath. It may be the result of or result in hypoxemia. What is the difference between hypoxia and hypoxemia? Remember, just like the word anemia, we've all heard the word of someone, oh, they're anemic. They have anemia. Emia means in the blood. Okay? So, emia, hypo, low oxygen in the blood. Hypoxemia means low oxygen in the blood. Okay? Determine when assessing the patient with respiratory distress, right? So these are all questions that you kind of internally ask yourself, but for now, it's not a bad thing to maybe say them out loud to at least put your thought process into, action. Okay? So how's the patient positioned? Are they face down in a pile of vomit, right? Are they underwater in the bathtub, right? Are they sitting at the bottom of the pool looking up, right? So how are they positioned? Are they in the tripod position? What position did you find them in? Remember, the tripod position is when you put your hands on your knees and you lean forward. We've all been here. If I tell you to run to the stop sign and back, first one back passes EMT program, right? You're going to come back cuffing and puffing, and you're going to put your hands on your knees to try to open up and expand your lungs and to facilitate ventilation, okay? So another question we could ask, is the patient experiencing orthopnea? Remember, orthopnea is when someone gets short of breath laying flat, typically, or at least not sitting up. So these are the patients that like they have to sleep in a recliner because if they lay flat in bed, they can't breathe. They feel like they're drowning, right? And who gets orthopnea? I'll just tell you right now. These are patients with congestive heart failure. Okay, they have fluid in their lungs, so when they lay flat, they feel like they're drowning. What sound does orthopnea make with a stethoscope? Rails, wrong, or I'm sorry, rails and crackles. Okay, good. Now, is there adequate rise and fall of the chest? Okay, this is something that we have to assess. Is the patient gasping? Remember, gasping respirations can mimic or can be agonal respirations. So if someone's breathing like this, right, that's agonal respirations. By the way, I look like a fool for these videos sometimes mimicking patients, but I do it for you. So is the patient gasping? Okay, yeah, that can or are they just like right, like they're just truly gasping for air? That could be called air hunger as well. So there are different forms of gasping, but be aware that gasping could be agonal respirations. Those are not effective respirations. It's a sign of death usually, and then or someone's dying, and then they could be gasping, sucking in air. Okay, so what color is the skin? What color? Are they cyanotic? Cyanosis. Remember, that's the bluish color of the skin. Is it red? Is it gray? Are they pale? Are they yellow, which is jaundice? Right? Are they purple? Are they purple from the nipple line up? Right? These are all which would be a pulmonary embolism. Right? These are all things that we have to ask ourselves. Okay, is the skin moist or clammy? What is moist, clammy skin called in medicine? Diaphoresis. Remember? So if I wanted to describe someone with like moist, clammy skin, like they're real sweaty and slimy when they shouldn't be, diaphoresis. Okay, or I would say their skin's diaphoretic. Now, you see, I will say you see this next one more so in kids, but it's still good to know. Is there flaring of the nares? Okay, so the nares is the opening of the nose, and so when we suck in a lot of air and we're really working to breathe, they kind of flare in and out with each breath. You see this in kids. So I'll say this again. You see nasal flaring as a sign of respiratory distress in kids. Watch for this. Dead giveaway. Put oxygen on them if you see this. Okay? But you can see this in adults as well. But you will see this in kids like that. Tall tale sign. Okay? Now, is the patient breathing through pursed lips? Same thing, guys. I wish I was in person with you. I would say go run to the stop sign and back because you would all experience this. If I tell you to run the stop sign and back, some of you are going to be like, right, trying to catch your breath. Why is that? You're self-peeping. It's auto-peep. You are closing off the amount of air coming out of your lungs so it opens up the alveoli. We could demonstrate this with a balloon, right? If I were to take a balloon and just let go of it, the air, that balloon will deflate rather rapidly. But if I just let a little bit of air out, or only like I unpinch half of the escape valve of the balloon, that balloon's going to stay inflated. And these balloons are our lungs and our alveoli. So we breathe through pursed lips in respiratory distress. You and I do this, but who else does this? Emphysema bronchitis patients. Remember the pink puffers, emphysema, right? Pursed lip breathing. Now, one thing I want to point out, very important to know, is children will grunt. Children aren't smart enough yet, less than a year. They are maybe a year and a half actually. They're not smart enough to pursed lip breathe. Okay, so what they will do is they will grunt, and you see this in kids a lot. It's very ominous. It means they're in severe respiratory distress. So what will happen is they'll go like, to me it sounds like a whimpering sound. You can see this in adults, by the way, but you'll see this in children, and so it sounds like a right? And what's happening is they're not pursing their lips to create that back pressure in their balloons, their alveoli and lungs. So what they're having to do is they're partially closing their glottis, their vocal cords. So there's back pressure from their back. So pursed lip breathing is a very good way for kids to auto peep, self peep, right? Remember, peep, positive and expiratory pressure. Do you know any retractions? What are retractions? This is a lot of kid stuff. Kids have very compliant chest, right? So their chest is real squishy. Okay, their bones aren't very solid yet, and so what happens is their chest is so compliant that they can end up sucking in different parts of their chest when they're working really hard to breathe. Where do we see that? The first place you'll see it is right underneath the rib cage. You'll see it sucking in when they're breathing. Okay, that's called retractions. You can see this, and you will see this in adults as well, which is very obvious in kids. And you will also see what they call or not subcostal, substernal. I can't think of the word. Up in the neck, you'll see this up here in their neck. You'll also see it sucking in with each breath. And so that is called retractions. It's a very ominous. It's not ominous, but it means that they're in respiratory distress, and it's something to be aware of. Okay. Is the patient, again, moving symmetrically? Did they choke on something? Do they have a hemothorax, a pneumothorax, right? Did they blow a lung? Is there a big old chunk of grape stuck in their lung and it's shutting off the right mainstem bronchus, right? These are all things we have to look for. So is the patient taking a series of quick breaths followed by a prolonged exhalation phase? So again, you've done this. If I tell you to go run really fast, you'll come back and be like this. You'll come and be like, right? Like you're really trying to catch your breath, okay? So just be aware, different patterns that this can present, okay? So the patient, labored breathing. So, we don't say they're breathing bad. We say, oh, they have labored breathing or they're in respiratory distress, okay? Patient with inadequate breathing may appear to working hard to breathe. So you can also see this is accessory muscle usage. What's called belly breathing. So the main muscles of ventilation, right, or the diaphragm, we've talked about that, and the intercostal muscles, your rib meat, okay? Now, those get tired, okay? They're not designed to work really hard, or like, quote, lift a lot of weight. So what happens is when those tired, we can start using accessory muscles. One you will see in adults especially is belly breathing, where they start using their abdominal muscles to aid their diaphragm in moving, okay? So they'll literally be using their belly to aid in their breathing. So you'll see their belly moving a lot with breathing. Okay, that's a bad sign when that happens. The sternocleidomastoid, this is the muscle right here on me. They could use this as well to aid in breathing. And the pectoralis major, so these are your pecs, this is your chest muscles. Okay, they could use these as well. I would say though, the more obvious one that you're going to pick up like that is the rectus, is the abdomen, right? The abs. You'll see, and yes, fat people have abs. So yes, everyone has abs. You just may not be able to see them, but they'll use their abdomen to breathe. Okay. Now, again, signs of inadequate. So we keep hitting this because you have to be able to recognize this like this and intervene. So respiration, generally, as respiration is less than 12 or more than 20, is generally a sign of inadequate breathing in adults. Generally, okay? An irregular rhythm, right? Are they taking 3 breaths and then holding their breath for 10 seconds? That's an irregular rhythm, okay? Should be very rhythmic, right? Like a rhythm. Is there diminished, absent, or noisy auscultated breath sounds? Auscultated, right? That's just listening. So, are they just the right lower lobe got a big pleural effusion and it sounds diminished, or are their entire right lung absent because they choked on a grape or because they blew a lung or whatever? So these are all things we look for. Abdominal breathing, that's the medical word. You're right. I was calling it belly breathing. Pardon my Texan. But reduced flow of expired air. This is annoying. This is obstructive pathology because we don't really assess this, but in the pre-hospital environment. But this, you'll see this in asthma, COPD, emphysema. Remember, most lung pathologies we're going to talk about in this course are obstructive pathology. You have a hard time getting air out, okay? Unequal or an inadequate chest expansion, okay? Another thing that you could have is what's called a flail chest, where you break 3 or more, or 2 or more ribs in 2 or more places, and so you will end up with your chest rising asymmetrically. Okay, that can happen. So if they have increased effort in their breathing, so breathing should be pretty natural, pretty chill, just like you are now, hopefully. So if they're like thinking really hard about breathing, right? That's not normal. Okay. If it's a shallow depth, what causes shallow breathing? Sleep is one of them. But what also causes that is alcohol, benzodiazepines like Xanax, narcotics, opioids, okay? Fentanyl, heroin, oxycodone, morphine, okay? Skin that is clammy, cyanotic, cool, mottled, or moist. It's getting repetitive retractions. We talked about that. And staccato speech patterns. So if any of you play an instrument, you should know what staccato is. A staccato note is a choppy note, right? So what happens if the staccato speech pattern is sound like this? I can't breathe, please help me, right? So they're just very ba, 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 right? It's staccato. So it's called a staccato speech pattern, and it means that they're short of breath. Again, it's the same thing if you ran at the stop sign and back, and I start asking you to, tell me where you were born or whatever, or your favorite vacation, you're going to have to give it to me in really quick breaths first, so it sounds staccato. Auscultate, I'm not talking about that anymore. Feel for air movement. I think this is undervalued. Do be aware that you got to be careful. I mean, it's weird that I'm even telling you this, but you have to be generally aware of staring at a woman's chest, right, male or female. So you just have to be aware, right, that if you're just like staring at a woman's chest, male or female, it can create a problem. So be careful with that. Same thing with palpation. You need permission to do this, right? Any part of treatment, you need consent. So basically, I might just say, hey, I'm just put my hand on your shoulder. Is that okay, right? And then I'm going to use the back of my hand. If you ever have to feel the chest, it's generally better, especially for men, to palpate with the back of your hand. It's because it's groping, like gripping, is generally it's inappropriate. Okay, so evaluate for pulsus paradoxus, excuse me. This is complicated, but basically you'll have pulse that don't match up. We'll talk more about this in chest trauma, but you don't need to know at this exact moment. You'll see that in cardiac tamponade. And so this is an example of Cheyne-Stokes respirations, and I'm going to talk about this. Yes, you need to know what Cheyne-Stokes is, and it's not Chine, it's Cheyne-Stokes. So in serious head injuries, you'll end up with an increased intracranial pressure. Grandma fell in the shower, whacked her head, someone had a big stroke, hemorrhagic stroke, something like that. Okay, big brain tumor, something happened to the brain. And what happens is when the brainstem gets jacked up, when it gets pushed on specifically, this is from an increase in intracranial pressure, you see Cheyne-Stokes, you'll see a crescendo decrescendo pattern. And so what this sounds like is they'll go like this. I always feel like such a loser mimicking these for y'all, but they'll go like this. Right, so you notice my breathing starts slow, gets louder, 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 then it gets soft, and then there's apnea. Right, and then it starts slow and it gets louder, 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 and then it's apnea. And how this will be described so if they describe this to you, they're not going to use the breathing gets slower and faster and it stops, right? They're going to say there's a crescendo decrescendo pattern with apnea. And again, if you know anything about music, if I were to take my piano and just roll up the keys, right, that's a crescendo, right? And if I were to go down, it's a decrescendo. And so it's a musical term actually. And so you'll see it getting louder and then softer. So again, how they describe Cheyne-Stokes respirations, it's actually almost always due to increased intracranial pressure, usually due to head trauma or from like a stroke, hemorrhagic stroke. How this will present, how they'll say this, is the patient breathes with a crescendo, decrescendo pattern with periods of apnea. Okay, remember apnea means not breathing. So that's worth knowing. This is ominous. I've only seen this a few times. And actually one time it was on a family member. And so this is very bad when this happens. It's very close to death. You'll see this in hospice patients. Okay, so just be aware. This is. I mean, if you see this, you need to grab this, right? You need to grab the BVM because they're not breathing adequately. Okay, remember agonal gasp, right? Are not actual. We don't count those, right? So they're not actual breathing. So someone going, oh, right, and holding their breath for 20 seconds, they're not breathing. You start CPR. Okay? So we just have to be vigilant, right? And just know that respiratory distress can change like that. Better or worse, usually worse, right? So just know this is very dynamic. Second to second, the respiratory system, it changes very, very quickly on these people, okay? So just constantly reassess them. Don't get caught with your pants down and be like, well, they were breathing fine when we got there, right? And now they're in like respiratory extremists when you get to the hospital. So just be aware, like patients do change, okay? This is something that we have to be experts at fixing. So be prepared to fix it. Be good at fixing it. All right, so assessments of respirations. So the level of consciousness and the skin color, along with cap refill. Remember, cap refill where you push on the skin should refill in 2 seconds or less. Really good indicators of good respirations, okay? The baseline mental status is really good. So what I like to ask is the patient behaving how they normally do, right? Because if they're 95 years old and they're always confused, right? But a 22-year-old should not be confused typically. So I like to ask, is this how they normally behave, right? Is this their normal? Um, and the reason that we look at mental status and level of consciousness to assess respiratory system, you're like, what? Neurology, respiratory, those aren't related. Well, they are, because remember, the brain requires oxygen so much that it's going to be the first clue, generally, the first clue to say something's wrong. When someone doesn't have enough oxygen, the brain will be the first one to start messing up. Okay? And how does that present? Altered mental status, irritability, agitation, decreased level of consciousness, unconsciousness, right? So these are things that we'll see. So in the pulse oximetry, we'll talk about that here in a minute. Well, this is pulse oximetry, right? So we've all had this, okay? It's typically assessed on your finger. It can be assessed on your earlobe or on your toes or on your nose or on your forehead or on wherever, okay? Basically, there's a light passing through. Let's just use my finger. And there's a sensor on the other piece of that light. And so what happens is it's measuring how much the hemoglobin is saturated. Not necessarily what it's saturated to. Hopefully it's oxygen, but it just determines how much is it saturated. Okay? And so typically this should range between 94 and 100% in most of us. Okay? When it's less than 94%, we start treating it with oxygen typically. Now, we can use this for trends. And so if we get there and it's 87% and we put on an on a breather and it goes up to 98%, then we can put in our chart and tell the ER physician, hey, we gave an on a breather and there's SATs. And by the way, it's SATs, S-A-T-S. Do not call it stats. This is not a statistics class. SATs, S-A-T, like saturation, oxygen saturation, right? Not oxygen saturations. So it's oxygen SATs. Don't call it stats. Okay, so anyways, so I'm going to call them SATs, but no, I'm saying SATS. Okay, so you can walk in and be like, oh, hey, their SATs were 88% on room air, and we put on another breather at 15 liters a minute. Now it's 98%, right? So you could prove like, oh, hey, your intervention did well, right? You did the patient well. And so you can also, and the opposite could happen, right? You get there on scene and it's 94%, and you're like, all right, we're just going to sit and watch. And it goes down to 82%, and you're like, oh, wow, we better do something. So you need to intervene. And then before we get to this last one, which I love that they put this in here, I want to point out something. This is delayed by like 30 seconds to a minute. What? No, it's actually measuring each pulse beat by beat, okay? And I've talked about this. It's measuring it beat by beat. So what you're seeing on there really is their current pulse rate, but the percentage gets a little delayed. What does that mean? If I were to take you, right, and it's at 100% sitting here in room air, and, okay, maybe not you, a willing participant, and you start choking them, right? You completely shut off their airway, or you ask them to hold their breath, right? That's probably a little more PC. They hold their breath. Their SATs will start dropping, but the actual drop in saturations in the blood, it's going to happen quicker than what this machine's going to pick up. So why am I telling you this? Realize there's about a 30-second to 60-second lag. So you can't just put on a non-breather on someone and be like, oh, what's the SATs now? 5 seconds later, right? They're not going to change like that. It takes a minute or two for these things to happen, and there's a lot of science to this that we don't really need to know at this exact moment, but no, there is a little bit of delay in this. Moving forward, these are really good to assess vascular status and orthopedic trauma. What? So we're going to talk about this in orthopedic trauma, which is known as like broken bones. If someone like, I don't know, breaks their arm, right? They take a baseball bat to the arm, break their humerus, mid-shaft humerus, right? Snaps it in half. It's a real big deformity. Looks like a question. Their arm looks like a question mark, okay? And you're like, oh, wow. What you have to worry about was there vascular damage? And so we have to find pulses distally, like the radial pulse, and we'll check cap refill distally, right? And that's really helpful. But sometimes that's really difficult, especially if they're in pain or if it's splinted, right? So if you splint it over the radial pulse and you can't reach the radial pulse, what you have to do is, or what you can do, is you can take that pulse oximetry and move it to the patient's right finger. Maybe that's exposed, or their pinky or something like that. And you can put it on there. And if it's showing 98% on the broken arm and 98% on the unbroken arm, then you know there's good blood flow making its way all the way down to the right finger. That's where the right humerus is broke. So this becomes really good in assessing, like I said, orthopedic trauma. This becomes really nice in your chart as well to say they had a 98% O2 sats of the right finger, before and after splinting. So you could say like, oh, my splinting certainly didn't cause more vascular damage, and it was the same before and after my interventions. So, it's a good tool to use. I almost deleted this, but I left it in here. I will not test you on this, but let me explain this. Remember the whole obstructive pathology thing, asthma, COPD, bronchitis, emphysema. What happens is, remember that you have a problem getting air out. Well, they have these tools called peak expiratory flow. And so what happens is, this is crazy because you don't do this when someone's acutely ill, is you tell the patient, I want you to take a deep breath in and I want you to blow out as hard as you can. And you see what level that is. Like, how hard did they blow out? And so if they're having like a big old asthma attack, they're not going to be able to blow a lot of air out. And then you're going to give them like some beta-2 agonists like albuterol. And maybe you could reassess your intervention by telling them to blow out again. And how you do that, and then so you'd be like, oh, well, the number got better. Okay, after my intervention, I gave them some beta-2 agonists like albuterol, and the number doubled or whatever. You could show that your intervention was helpful. Now, the problem with this is good luck convincing a patient. First off, I don't know any ambulances that carry this, at least in Texas, but good luck convincing a patient who's in respiratory distress to do a silly test like this, right? Where this is typically used is in doctors' offices. They'll ask patients to do this, but hospitals too. But like on the floor, not in the ER. I've never seen this done. I've actually, let me take that back. I've never seen this done until medical school. Never saw this done as a paramedic. But that's what they're assessing. So again, obstructive pathology, which is most lung pathology we'll talk about in this course, hard time getting air out. What sound does that make? Categorically, wheezing. Is it on inspiratory or expiratory that you're going to hear this noise? Expiratory. When they're breathing out, it's going to make the high-pitched noise. Expiratory wheezing, obstructive pathology, asthma, COPD, emphysema, bronchitis. That's them. Okay? Now, ABGs, arterial blood gas analysis. There are ambulances that are carrying this now. EMTs won't do this, but your paramedic partner might. These are basically where normally it's capillary blood gases that they're doing actually, or venous blood gases, but these are complicated because what they do is they take a needle and they stick it in like the radial artery, pull out some blood, right? And then you can put it into a machine. It can tell you like the pH of the blood and how much oxygen is actually dissolved in the blood and CO2 is dissolved in the blood, and all these numbers that can be helpful diagnostically. But I mean, this is pretty rare to get an ABG. Normally it's a capillary blood gas or a venous blood gas. Now, so I wouldn't spend much time on that. Now, end-tidal carbon dioxide assessment, I've said this a lot, it's probably my single greatest tool on the ambulance because it measures CO, or way to go, JB Learning. It's CO2. Detects the presence of CO2, not carbon monoxide, carbon dioxide. So it detects the presence of CO2 in exhaled air. So that threw me off that they used CO2. Like, what a typo. And so, anyways, we'll talk about this coming up right here. So, as we know, when we breathe out carbon dioxide. Carbon dioxide is acidic. What happens is one way we can test this is by having it blow across a piece of litmus paper, right? Just like in science class, when you dip acidic stuff, it changes color. Well, someone was smart and they created a device. And I don't have one here, but what you do is when you breathe out, it'll change colors, right? I think it's normally purple, and when you breathe out, it'll turn yellow. And so basically, like I said, there's a piece of paper here, litmus paper, and so it changes when the patient breathes out. So it's a good way to know that your endotracheal tube is in the right place. This is an older device, but this is a capnometer, right? And so basically it'll give you numbers of how much carbon dioxide they're breathing out and the times of the minute that they're breathing. Don't see these very often because they've been replaced with this thing I'm about to show you. This thing. So this thing is entitled waveform capnography. And so what this is it's measuring how much CO2 is in the in exhaled air. And typically this is 35 to 45. And in class, remind us, we'll pull one out and let you play with it. What we'll do is we'll put this on on one of you, a student, and we'll let you breathe, and you can see your pattern of breathing up on the screen. And so first off, this is measured on exhalation, right? So we breathe out carbon dioxide on exhalation. And so what happens is when you start breathing out, right? So this is this phase right here is inhalation, right? And so when you start breathing out, air starts emptying out, and then it plateaus, right? Somewhere, let's just say it's 40, because the normal range is 35 to 45. And then what is this sharp dip down? This is when they inhaled, okay? And so it creates this pattern, right? And we can look at this pattern as paramedics for pathology. And interestingly, well, what if someone has obstructive lung pathology like asthma? Glad you asked. It creates a certain pattern called shark finning. So it looks like this, right? And so you'd be like, what? That looks like a shark's fin, like the dorsal fin on a shark. It does, but it's because they have a hard time getting air out. So this whole expiratory thing right here, this is the expiratory phase, it gets delayed, okay? So it creates a shark fin pattern. You'll see this on your clinicals. Or maybe we can find a smoker on a lab day or something, you could see this, but it's interesting to see this. So this is a waveform capnography, very great tool. So just know this is what it looks like. I will say these are fairly expensive. These are about $40 a piece. Okay. So we don't use these on every patient, but they are very helpful. And so, and actually there's a law in Texas now that you have, if you use like endotracheal intubation to stick the tube down someone's throat, which paramedics do, you actually have to have this device on your ambulance by law to confirm it's in the right place. Why is that? Because when you're sticking that tube in someone's mouth, you can either go in the trachea or the esophagus. That's the two places, that's the two holes. So if you stick it in the wrong hole in the esophagus, there's no carbon dioxide, or not much, carbon dioxide in the esophagus. So as you start bagging them, you're going to have food and shit coming up the tube, but you're not going to get any carbon dioxide up the tube. So the reading on your monitor will be like 0. And then as opposed, if you put the tube in the right place, the trachea, you're going to get a consistent reading on your monitor. So it confirms you're in the right place. And then this last one is really interesting. So you can use this to determine the adequacy of chest compressions and to determine if you've had ROSC. What's ROSC? This word right here. It's the return of spontaneous circulation. So when you're doing CPR and you get a pulse back, that's called return of spontaneous circulation. And so, you know, if you're doing CPR and it's normally like 10 to 12, like you remember the normal is 35 to 45, and let's just say this whole time you've been doing CPR and it's 12, and it suddenly jumps up to 88, right? Really high. You're like, oh, wow, the pump just kicked back on, right? The heart kicked back on, and it started grabbing all the CO2 that was stuck in the brain and stuck in the big toe and carried it back to the lungs, and now it's finally being exchanged, and so you're breathing it out and you're sampling it. So that's why we use that. This is used a lot in CPR. Very helpful. I think, let me check one thing. I thought that I wasn't going to go into that yet. No, we are. Okay. We're going to go into opening the airway, and then we'll talk about airway adjuncts. So this will make more sense in class. We have like really nice fidelity, high fidelity airway mannequins. So for now, let me just try to stumble through this with some pictures. We will get very good at this. You're going to do this a lot in class. Okay, this will become very natural. So to open the airway and assess patient breathing, the patient needs to be in the supine position. Yeah, if they're unconscious, they need to be in the supine position, or at least in semi-Fowlers, right? Kind of somewhat sitting up, or Fowlers, completely sitting up. And just be aware that supine is laying on your back, prone is laying on your stomach. And so when someone is unconscious, right, like let's just say like they've had a big stroke or something, or they've overdosed on something and they're unconscious. What happens is the muscles in the mouth and especially the tongue will relax, and that big fat tongue will fall back. And when that falls back, it occludes the airway. And in fact, if you wonder what causes snoring, this is what causes it, right? When you're sleeping, your airway muscles become too relaxed, the tongue falls back, and it creates snoring. And so this creates a problem. And so we need to open this up. And so there's like two main different maneuvers that we use to do this. The first one is head tilt chin lift. So what you do is you take the patient's head and you'll kind of lean it back, you'll extend it, and then you're going to take the chin and you're going to lift it up, right? And so by doing this, you're creating a larger passageway for air to come through, and hopefully the tongue is no longer occluding the airway as much. And that's one way to do this, okay? So the head tilt chin lift. It's very common, right? We use this a lot. If you did a BLS CPR class, like you've been taught this, okay? Now, when do we do this? On medical patients, okay? So medical patients, no falls, no trauma. We're not worried about neck issues. We can do this. So if they have neck trauma, right? They fell in the shower. We found them face down in the kitchen, right? We assume they fell, right? Then you can't do this, okay? Because you're friggin' hyperextending the neck. If their neck's broke, you just broke it more. So, maybe. So just be aware, you can't do this if you suspect cervical spine trauma, you can't do this particular maneuver. It's replaced by something else called the jaw thrust maneuver. The jaw thrust maneuver is going to be hard to do on myself, but I'll try. You take the jaw and you're like gonna, I can't do that. My arm's cramping. You're going to take the jaw and you're going to like lift the jaw out, right? And you're like thrusting the jaw up. Who does that? Who gets this? Trauma patients. Also those in C-collars. And so this is a really good way to open up someone's airway, okay? So this test question coming, I promise, okay? If someone has a cervical spine injury, we do the jaw thrust, okay? Do not pick head tilt chin lift. You cannot hyperextend a broken neck, or you can, but we don't. We're good. Okay, so place the fingers behind the lower jaw, and you're going to move the jaw upward. This will make more sense when you do this in the lab on an airway mannequin. Okay, be very careful doing this one. I almost took it out, but I think it's worth knowing. I've only done this like once or twice, and it was like a kid, and then once was an adult. Okay, you can literally go in there, grab the tongue and the jaw and lift it, okay? Remember, the tongue's falling back. So if you take that puppy and just yank it forward, okay, then, and lift the forehead back, right? You can really open it up. What's the risk of this? Losing your friggin' thumb, okay? If the patient suddenly decides to stop faking or has a seizure and clamps down, right? Trismus, right? Guess who's losing their thumb? You. So be very careful with this. So do we do this on patients that have had a seizure or on patients that are actively breathing? No. The only time I would do this is if the patient has A, no teeth, B, if they are like dead. Like I don't have to worry about them biting me. Okay, so be very careful doing that. I would personally do jaw thrust before this, or use an OPA. Remember, or you don't know yet, but this thing goes in your mouth like this. Okay, so we'll talk about what this is. This lifts up the tongue. Now, we should pace the patient in the recovery position, ideally on their left side. Can't get them on their left. Okay, put them on the right. It's okay. Ideally on their left side. We've talked about why the inferior vena cava runs on the right. So you don't want to squish it with all their guts, so you just roll on their left. And so the reason we roll them on their sides is if they vomit, they're just not laying flat on their back, like, right, like right into their face. So, of course, we don't put patients in the recovery position if they've had a traumatic injury. So if they're vomiting and they fell 12 feet off a ladder, we don't put them in the recovery position. We have to maintain C-spine and roll them while maintaining C-spine. And then suction them aggressively with a yonker, okay? So we'll talk about that. But, speaking of suction, good stuff. I intentionally am going to make you suffer through hearing me open these up. because it takes a while. So on most ambulances, these stay at the captain's seat, and they stay like, I don't know why, because they're not sterile, but they stay all wrapped up. Okay, so bear with me as I open these. Open up the suction, turn it, open it out. I'm going to attaching it to the suction canister over here, getting out my yonker. In the meantime, your patient's vomiting, right? I'm getting out the yonker. Which way does it go? Okay, it goes this way. Okay, got this. Okay, and I've done this before, so that was what, like 20 seconds? Well, now your patient has swallowed a lot of beer and taco vomit. So the point I'm making, this takes a while. So if you have any inclination that your patient might even possibly at some wildest dream need suctioning, you should have this open and out and the suction unit turned on. Costs no money. Okay? So just be aware this takes a while. And so this is there's portable suction, right? This is a handheld one. If your agency uses these, RIP. But there's also like a it looks like this, like a mechanical suction that's handheld, like it's a machine. They're very expensive. I don't know why. And then there's always going to be one mounted on the wall in the ambulance by the captain's seat near the patient's head. Okay. Oh yeah, there's portable suction, and so that's what that looks like. And so, this is pretty wide bore stuff. It's pretty heavy duty tubing. Okay. It shouldn't kink very easily. And so this is a rigid catheter. This is called a decant-2 catheter. This is the cat's meow. You can see that there's holes right here. You see how there's a hole in it? Okay. Why is that? It's in case that this gets a big old chunk of steak in it, it's still suctioning through here and vice versa. If these get clogged up. So it gives you additional ways to allow suction to continue taking place. Now, supply of water for rinsing the tips. Sometimes if this gets like really thick mucus or really thick whatever, you might have to like dip it in some water to get it cleared. And the other thing I'll say about this is what I do if I'm like, oh, my patient might need suctioning. I just open this up and I put it up underneath their pillow. So it just sits behind their head. And so I sit it behind the patient typically. And so if like they're like, right, like I'm already grabbing this sucker and I'm ready to go, and I'm ready to go into their mouth and start suctioning. Okay. So this is a rigid, like the decant-2 I showed you, right? This is a rigid one. This one has a little bit of a softer tip, like not soft, but rounded tip. This one's pretty aggressive. You do got to be careful. You can't go like really crazy. You can cause trauma with these, basically, is what I'm saying. And then they also have a French tip. And I really thought I had one, but apparently I don't. But a soft tip, okay. The rigid tip is used to suction the mouth, okay? But a soft tip catheter is used to suction the nose and tubes, right? Like an endotracheal tube or something like that. So just be aware of the differences. As an EMT, 99.999% of the time, you're going to be using this, okay? This is important right here. Okay, let me just read these. Make sure that your suction unit's working. You should not, or test it to ensure the vacuum has more than 300 millimeters of mercury of pressure. It's a fairly large amount of pressure, okay? So make sure that it's actually working at the beginning of your shift. Make sure you have the right tubing. It's all there. It's ready to go, okay? Your agency may not let you take it out of the wrapper. If so, they're poor. Work for an agency that'll let you, okay? And empower you to be a clinician and make good decisions. And so I would almost always take mine out of the wrapper and just put it over there real neatly at the beginning of my shift. And this is important. You have to limit the suction time. You have to limit it, okay? What does that mean? You can't just throw this in my mouth for 30 seconds. Why is that? First off, it can interfere with breathing, okay? Now I get it. If there's a bunch of beer and taco vomit in my mouth, you got to get it out. Suction for 15 seconds, ventilate the patient, suction for 15 more seconds. Coming up on an exam near you, they're going to ask this. And then more so in kids, you're going to notice Why is it 15 here and then 10 seconds in children and 5 seconds in infants? There's a very good reason for this. Very high yield. The reason is because the vagus nerve there's several parasympathetic, but the vagus nerve runs through the back of your throat. And so when you push on the vagus nerve with anything, right, it gets stimulated. And what does the parasympathetic nervous system do? It slows down the heart rate, right? It's the rest and digest. So if you stick this in a kid's mouth for like 20 seconds, right, you're going to stimulate that vagus nerve so much their heart rate will go from like 130 to 70, right? And so you're causing harm. So, rule number one of medicine, do no harm. So you have to limit your suctioning in kids. And I'm not kidding. If you're not like 1, 2, 3, 4, 5, out, like count it out. Because remember, 5 seconds to you is very different under stress than 5 seconds listening to me talk right now. So it's okay to be like 1, 2, count it out and set your limits. Test question coming near you. What is the consequence of suctioning for too long? Overstimulation of the vagus nerve, which is in the back of the throat, which will cause stimulation of the parasympathetic nervous system, which will cause bradycardia, which is a slow heart rate. Okay? Very important to know what I just said. Now, this is a soft tip suction catheter. I don't have one, but it looks like this, more or less. And what you do is you stick it it's attached to suction, you stick it down an endotracheal tube, and you suction on the way out. Okay, we'll show you that in class. I don't have one with me, I'm sorry. Now, really good tool. This is called the oropharyngeal airway. And they can look like this, okay? And they can also look like this. And they can also look, show and tell with Hunter, like this. It's a little baby one. See the size difference here? Okay, so these are oropharyngeal airways. And how these work is we stick this, first off, we have to appropriately size this, okay? And how do you size it? It's from the angle of it's from the corner of the mouth to the angle of the mandible, right? The mandible is like this thing right here, okay? And so what you do is you put this at the patient's mouth, and you want to see if this tip reaches back here at the mandible, okay? And actually, for me, it does. So this is the right size for me. And so what you do is you put this in the patient's mouth, and there's a certain technique. You can start at like a 180, you put it in, and you rotate as you're going back, or you can start at like a 90 and rotate it and go in. This is new, by the way. And so what this does is it manually will lift up the tongue, and there's like air passageways through here. So we use this in patients in cardiac arrest. Okay, it's very helpful to lift up the tongue. So instead of someone having to sit there and like constantly jaw thrust or head tilt chin lift, you pop one of these puppies in there, and then the tongue's lifted. It's out of the way. You can just use the BBM with this, right? Very helpful. The patient will no longer be snoring. Cool. Now, there's a big problem with this. What happens in 85% of the population when you touch the dangly thing in the back of the throat, the uvula, right? They gag. And so you can't put this into someone's airway if they're conscious or if they have an intact gag reflex. And so to simplify that, when do we use this? You can only use this in unresponsive patients with no gag reflex. And you're like, well, God, Hunter, how do you test a gag reflex? Well, yeah, that's what I'm saying. So it's very difficult to do that. So typically, Hunter Harbold reserves these for patients that are dead. Dead patients don't have gag reflexes, right? The gag reflex is part of the brainstem, and if they're dead, the brainstem's turned off, so they won't gag. So just be aware of that. Now, I've put these in patients before, and they were doing fine, and then like they start gagging, and you're like, oh shit, and you'll pull it out. So just be aware. Test question. You put in OPA, you start ventilating the patient. 5 minutes later, they start gagging. What's your next move? Remove the OPA. Okay. Patient is unconscious, cyanotic, and I don't know. They paint the picture of a really sick patient, and they have snoring respirations, I should say. what should you do? You can drop an OPA, okay, an oropharyngeal airway. Now, this is often used in conjunction with a BVM like this, but it doesn't have to be. If a patient's breathing 16 times a minute, 12 to 20 times a minute, and they have adequate rate and depth, but they're just snoring, you could, in theory, drop this into their mouth and lift up the tongue, and they'll no longer store or snore, and you've cleared their airway. So just be aware that the big consequence of this is forcing someone to vomit, gag, and then vomit, and then you got a real problem on your hands, because then you just cause harm. And rule number one is cause or do no harm. So just be aware. Okay, we'll talk about how to put these in properly in class. There's a whole little technique to properly sizing them and putting them in. It's its own little skill station, but it's not hard. And they're pretty good tools. Like these are good. They're very cheap. Okay. And then we have these things called nasopharyngeal airways. Well, the cool thing about this is this goes, as you could imagine, through the nose, right, and to the nasopharynx. And so it bypasses so it doesn't fully touch the back of the throat. So the cool thing about this is it can be used when the patient has an intact gag reflex. So the consequence with this is it cannot, write this down, you cannot use a nasopharyngeal airway if there is suspected head trauma, right? Any type of head trauma, nose trauma, face trauma, neck trauma. If there's trauma from here up, don't use this. Why is that? It's not a misnomer. If you shove this in someone's note and they have a fracture of the cribriform plate, the little nose bone right here, you can, and I'm not kidding, shove this into the patient's brain. Okay? So you cannot use this in any form of head, face, mouth, nose trauma. Do not use a nasopharyngeal airway in head trauma. Wrong answer. Now, you can use this in an awake patient. No way I'm about to do it, but there's videos all over the internet of like military guys. They'll just take these, right? They'll just lube them up. You want to put lubricant on this, like KY jelly, water-based lubricant. And there's a whole technique of properly sizing it, right? It's from the Nair to the same thing. This one's way too big on me. But basically, you put this in their nose, and it creates a patent airway for them. Now, again, we don't use this in head and neck trauma. These are measured in French. You'll see it says 28 right there. I'll just show you for size difference. Here's a 26 French. This one will probably fit me. Size difference there. Okay, 26 French. Still a little big. Okay, and I have a big head, figuratively and literally. So, you need probably 24 on me. But anyways, these are great. Now, question. What they'll do is call a double barrel. You could theoretically put this in both nostrils. Okay, and that's fine. So just be aware, they call those it's slang, but they call them double barrels. I've never done that. But these are good. These work well. And so, again, this could be a conscious patient, right? I could take you using this video. You're going to be very upset when I do it, but I could insert this in your nose, and you shouldn't gag if it's sized appropriately and insert it properly. Okay? Now, we use these MPAs in patients with altered mental status. Not all altered mental status patients, really. It's those that were worried about their airway. Patients who will not tolerate an oropharyngeal airway. Good point. Let's just say non-trauma patient, okay? Phenobarbital, alcohol overdose. Let's just use that scenario. They're breathing 6 times a minute. You try the OPA, they gag, you pull it. That's what we're supposed to do. What's your next step? Insert a nasopharyngeal airway, okay? And so if the OPA fails, the oropharyngeal airway fails because they gagged or whatever, and there's no trauma, you can insert the nasopharyngeal airway, okay? Now, again, if there is head trauma or head injuries, blood draining from the nose, bloody nose, anything wrong from here up, do not use this, okay? If there's a potential for the basilar skull fracture, the basilar skull is the bottom part of your skull, it's the base of your skull, don't use this. If they've had a previously broken nose, don't use this, right? If you're meeting resistance during insertion, don't use this. Why is that? The nose is very vascular. So if you shove this right through like this AV junk, right? Arteriovenous like junk, right? Like people that have like sinusitis will get like AV malformations in the nose. And so if you push through that, they're gonna bleed a lot, and it's really hard to fix that. So I mean, you have to burn it to fix it, is what I'm saying, like someone in the hospital does. So just be careful, right? Like, we don't force this in. It shouldn't take a lot of effort to insert these. We'll do this in the lab, and again, you'll be very good at these. Now, supplemental oxygen, good stuff. Love me some oxygen. Who doesn't? They're typically painted green. That is worth knowing. Okay, it's the international color for these. Make sure that it's labeled medical oxygen. Of course, and let me start with this. Oxygen is a medication. Okay, and then chapter 12, we're talking about pharmacology. So there's the rights of medication administration, right? Right patient, right dose, right time, right indication, right order, okay, right route. It is a medication, and you have to look at it like a medication. So you're like, oh, that's ridiculous. Oxygen expires. Well, yeah. Do you want to breathe oxygen from the rusty tank from 1955? I don't. So there's quality control in that. So just be aware. Oxygen does expire. Typically now these tanks are aluminum, by the way. So they're not like lightweight, but they're a lot. If you ever pick up a stainless one, like, or not stainless, a steel tank, you'll feel the difference. They're like twice as heavy. Now, I don't think that we typically carry it. And let me think about this. I think liquid oxygen has to be cooled. I don't think that the gas we typically carry on an ambulance is actual true liquid oxygen, because that's cooled. It's very cold. So, um, yeah, I don't know. I'll look into that. Anyways, be aware that these pressures are under like a huge amount, like 2,000 psi, 2,000 pounds per square inch, when they're full. So they're underneath like a huge amount of pressure. So they are, like, you want to go chunk them around. Make sure that they're properly secured. If these aren't secured and you roll an ambulance, like, that becomes like a 50-pound projectile. So be aware that it's usually positioned at the patient's head at that. So just be aware. They become missile-like. Like, I'm sure you've seen videos of like people shooting at these or something like that. All the air escapes and it creates like this rocket-like phenomenon. Okay. Now, they like asking this, don't ask me why, called the pen index system. Okay. And so what this does is it allows only oxygen regulators to be attached to oxygen tanks. So basically, there's like a system of pins that tell you that only fit onto certain tanks. And so you can't put like a helium regulator onto a oxygen tank. They're stored at different pressures, right? Different tanks. So they created this system that's very specific number of pins, and it creates, and it's known as the American Standard, or for large, yeah, the American Standard System, and it creates this safety mechanism to where, again, oxygen regulators go on oxygen tanks and oxygen, and it keeps the system like that. So it's a safety thing, and I don't know why, but they like asking that. I'll probably ask you about it too. Now, the pressure regulator is different than, okay, so 2,000 pounds per square inch is an unbelievable amount of pressure, right? And so, like, I mean, you're not going to, obviously, like, you'd literally blow the skin off someone's face at 2,000 psi, right? It'd cut through bone. So you have to reduce that to a usable amount. And so the usable amount's like 40 psi. And so the coming out of the bottle, it's going to reduce the amount of pressure coming out from like 2,000 psi if it's full to like 700 psi. And then there's a second one that'll reduce it to like 40 to 70. So basically, what we're using, like what we're seeing when we turn on an oxygen tank, and like what we're actually seeing is around 40 to 70 psi. Okay, if the regulator is attached. And so, let me show you what this looks like. These are both regulators. Okay, this is what you're going to see on a portable tank, right? And so it's measuring, like, that's 2,000 psi. So there's like 1,800 pounds per square inch in this tank right now. So it's underneath a tremendous amount of pressure, right? This is the pin index system. So there's like pins that allow this regulator, like male parts that go into female parts that perfectly align. If you put it on the wrong bottle, it won't align, it won't line up, so you won't be able to let air out, okay? And then this is the key. And so basically you have to have like a certain like a key, like a shake tool to open up that valve. Okay. And oxygen will come out probably down here. There's like an outlet valve. And so this is called, they call these Christmas trees. And so this is what you'll see on like the wall of an ambulance or in a hospital emergency room or a hospital room. And so to use these, I mean, it's very self-explanatory, you know, open it up or close it. And where this ball floats is how much oxygen you're giving. So if you want to give, you know, 5 liters a minute, you're going to keep turning the valve until the ball right there floats at 5. And you would attach this to that, right? Right to this little Christmas tree guy, okay? And also, you don't have to like screw this on all the way, just a little bit, okay? It's really hard to get off if you put it up there too high or too tight. Now, you're going to open the flow meter, so you're going to set it like 2, 3, 4, 5, 10, 12 liters, 15 liters, whatever you decide. And you're going to make sure that it's actually flowing from the device into whatever it is you're going to. So make sure, like I've turned on the nasal cannula before, but I didn't have the nasal cannula attached to the wall, right? So make sure that like at the end of the nasal cannula or the non-breather, that it's actually filling, you know, that there's air coming out, okay? You might have to adjust this. So I might start off someone in extreme respiratory distress at 15 liters per minute and decide, wow, they're doing a lot better. We'll go ahead and switch them to a nasal cannula at 3 liters per minute, okay? And then monitor the patient's reaction to it, okay? Disconnect the tubing from flow meter nipple and turn off the cylinder valve when oxygen therapy is complete. Yeah, you do want to turn these off when you're not using them or else they tend to leak. And then you get on to your next call and your tank's empty. Been there, done that. Okay, whoops, where'd I go? Okay, back over here. Let's talk about this. This is the last slide, I think. Oh dear. It's not, I lied. So, oxygen supports combustion. I want to say that again. Oxygen supports combustion. So, test question. Is oxygen flammable? Oxygen itself is not like flammable per se, but boy, does it help flames get hot. So, it supports flames, but oxygen itself is not flammable. Like methane or something like that. Hydrogen. Now, so it supports combustion. So what does that look like? Someone who's on oxygen smoking a cig, you'll see this. The people that still smoke while wearing oxygen, usually right here has been burnt because their cigarette got too hot and it started burning right here because there's a rich oxygen supply right here. So you'll see they get burnt right here. And so just be aware, oxygen supports combustion itself. Oxygen itself is not flammable. Now, oxygen can be toxic. And so be aware that while in the pre-hospital environment, it's pretty benign, it's a pretty safe drug. You know, we don't just get reckless with it and make it rain oxygen, okay? So what happens is as oxygen builds up, it creates these things called free radicals. And if you didn't know, in the body, I'll just give you one example of a free radical. H2O, which is water, if you add another oxygen molecule, it becomes H2O2, right? What's H2O2? It's hydrogen peroxide. And so if you put a bunch of oxygen in the blood and it starts binding to water, it can create free radicals, and these free radicals cause cellular damage, specifically at the DNA. And so it increases your risk for cancer. Free radicals, long story short, free radicals increase your risk of cancer because they cause DNA damage. And so that's something to be mindful of. And remember the whole hypoxic drive thing? That's also still something to be mindful of. Now, the answer will always be if someone needs oxygen, we give them oxygen. But that doesn't mean that every single patient needs a non-rebreather at 15 liters per minute. Okay? So there's this thing called FiO2. And this is the amount of air that is made up of oxygen by a percentage. Okay? And so let's just talk about some devices. Screenshot this, know this, these two things I'm about to show you. And so basically a nasal cannula, which remember like the nasal prongs that goes in your nose, it can so let me start with this. The oxygen in the atmosphere is 21%. The oxygen you and I are breathing right now is 21%. The air of your air right now is 21%. So got to know that. And so with each additional liter that you add about 4% per liter of oxygen. Okay? Got to know that. So, let's do this. Room air equals 21% oxygen. And you're going to get about 4% additional FiO2 for every liter of oxygen that you add. And so a nasal cannula, as you can see over here, at 0 liters per minute is 21%. So that's up here, right? This is room air. And so if we add a liter, it's 24%. If you add 2 liters, it's 28%, and 32%, and so on and so on. And typically, for the most part, nasal cannulas will stop around 6%, because much higher than that becomes really uncomfortable for the patient. Okay. Now, the other one I want to drag your attention to is we have these non-rebreather masks. That's this thing. And so what's happening is air gets pumped into this bag, so it's 100% oxygen, and then you breathe in from this bag. And so from this bag, you're getting it's a high percent of oxygen, around 60 to 95%, but it's usually in the 90s is usually what's tested. It's around 90%. So there's a lot of oxygen, okay? And the other one, and you might ask yourself, well, what about the other ones, Hunter? Okay, you don't necessarily need to memorize these other ones, but these other ones, they're variable. And so basically, as a paramedic, I might decide, well, I might want to do a lot of I can fine tune this, right? So I can set the ventilator, I can set the numbers on the wall and decide, well, how much oxygen do I want to give? We don't really do that at the EMT level, but just be aware. A non-rebreather is somewhere between 60 and 95% FiO2, which is the amount of oxygen in the air that you're breathing in. And then for every liter that you add to a nasal cannula, you're adding about 4% oxygen to the FiO2. Very important to know those formulas, okay? They're very simple. And that will occasionally be tested. So how is it tested? You apply a nasal cannula at 4 liters per minute. What? Blah, 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 blah. What's the FiO2? Okay. It's, did I say 4 liters is 36%. Okay. Simple math. Now, we have these different devices, right? Like nasal cannulas, non-rebreathers. Okay. I've showed you these. We're going to go into each of these independently. But this is a non-rebreather mask. Why do they call it a non-rebreather mask? Do you see right here this little one-way valve? Okay. The idea is when you breathe in, this valve will close, and when you breathe out, it opens up. So the idea is you should not be rebreathing your own air. You should be breathing from this bag. Okay. Now, a lot of times they'll be missing one valve by design in case you put this on a patient's face without oxygen, that they're still able to get air, right? So if I would attach this to myself, right, with no oxygen, in theory, I'm not getting a lot of air right now because I'm breathing it out through these one-way valves. So that's a non-rebreather. So we're going to talk about that. The problem with a non-rebreather is it doesn't provide true ventilatory support. So if someone's breathing 0 times a minute and you put this on them, they're still breathing 0 times a minute. So you can't use a non-rebreather. You have to use a BVM. Okay, and so that's a non-rebreather. Okay, and so these can be called a combination mask or a reservoir bag system. Typically, they're not, but they could be called that. Okay, now like I said, the exhaled gas escapes through that flapper valve. Okay, it's a one-way valve that allows air out. Okay. And so you want to ensure that this reservoir, right, the bag is filled all the way. So what you're going to do is you're going to turn this on to 15 liters per minute. So go to the oxygen tree, turn it up to 15. Air is going to be coming out. And typically there's a tube connected right here. And then so the air will come in through this tube and then down into this bag and it'll fill up. Okay. So we got to make sure that this bag is completely filled before strapping it to the patient's face. Nasal cannula, it's great, okay, big fan, works well, cheap, easy to adjust and fine tune. Patients love them. So yeah, I don't really know how to explain nasal cannula. It's a nasal cannula, you've probably seen one. Now these Venturi masks, I won't test you on these, but it's worth knowing. These are used more in like critical care, and so basically there's these different valves right there that are color coded that can determine how much oxygen can fit through that valve while mixed with atmospheric air to like determine the FiO2. So it will range somewhere between 24 to 48%, but it's mask. Now the thing is, you can get the same FiO2 with a nasal cannula. So these aren't very popular. Let me say the partial rebreathing mask, similar to a non-rebreathing mask, without the one-way valve. So if I were to take these two valves off right here, this is now a partial rebreathing mask. Okay, I'm gonna put these back on before I lose them. Tracheostomy mask. So this is tracheostomy is when they have a stoma or a trach tube down here. And so, well, let me take that back. A stoma is different, but a tracheostomy is they've had a surgical incision into their trachea, and it's further down here. These are on chronically ill patients, right, for a variety of reasons. And so there's a variety of indications for these, is what I'm saying. And so basically, you just put the mask over there. Now, I don't know anyone that carries a like an actual tracheostomy mask. The family might have one, but what you could do is just take your non-breather and put it over this. It's like it's close. It's the best you can do. Now, humidified oxygen is good stuff. So the oxygen in the tank's dry, very dry. And so if you put dry air in someone's nose, it'll get really irritated and dry, obviously, and it can cause bleeding and cracking and discomfort. So if you're going to do like a long-term oxygen therapy, you might want to have humidified oxygen. You've seen this on Grandma's O2 machine. What happens is it goes into here and it creates some bubbles, which humidifies it, and then the humidified air escapes through the tubing and goes into Grandma's nose. And so these are really helpful. They're pretty cheap. Sterile water is in the reservoir. These are single use, by the way. You don't reuse these from patient to patient. They're cheap, though. And I actually used to work for an agency that carried this. It was Erath County in the Stephenville area, because sometimes we could have like hour transports, or we would do, this is before my time, they would do transfers to like Fort Worth from Erath County, which is like an hour and a half, 2 hours. And so you would want to put the patient on humidified oxygen. All right, that's it for part 2. This last section is going to be very quick. It's talking about like combi tubes and King Airways. It should take like 20, 30 minutes, but I need a break, you need a break. So yeah, thank you for your attention.